that looking?
Yeah, great. We can see it. Thank you.
Lovely. Thank you, Vicky. Thank you, everybody. Yes, our physician here, Joshua, agreed to do this meeting, but then he decided he wanted to take a holiday instead, and so it's been left in my hands. But yeah, we've been open here at the PET service at the Royal Darwin Hospital for coming up to 2.5 years. Is actually the sort of 2 years and 4 months anniversary today of the PET service. Started in December 2018. So we haven't, for the last year or so, had much of an opportunity to have visitors come up here in 2020. So it's a good enough opportunity to give you all an idea of what we're doing up here. I picked a nice picture of Darwin. I'm trying to think of a funny title with like a storm of activity up here, or a change is coming. It's been a really good service and getting busier. There are changes coming in 2021 and 2022. I think it's really good. I just thought it's worthwhile to let everybody know what we're doing, and hopefully keep these connections open for between South Australia and Northern Territory. My talk is going to be basically just who we are, like just a view around the department here and the Northern Territory in general. Some brief discussion about how we've grown since then, how we've coped with COVID, as every talk these days has to have a little element about what you did in 2020. Our future plans are here for later on this year and for the years to come. And if we've got time, I have a little case study of a Malacca lady that we've had some sequential FDG PET images on. So there's time, I can do that as well if there's still interest at the end. Northern Territory. So we've got about 1% of the Australian population, sort of 2.5 to 250,000 or so people, of which about sort of 60% are in the Greater Darwin area. So it's reasonably centralised, but not quite as centralised as Adelaide, South Australia is. We have a large and sort of dispersed rural population who are a large portion of our Indigenous. There's lots of languages spoken, over 200 languages spoken in the Northern Territory, and lots of sort of communities and remote outstations where some people might speak English as a second or third language. The Aboriginal population of the Northern Territory, even though they're about 30% of the Northern Territory population, they're actually about sort of 70% of the public hospital patients for having sort of worse health outcomes at the moment. So it's really important up here to sort of engage with the Indigenous people and the Indigenous healthcare workers. As you would have in Adelaide, there's challenges about bringing people into Darwin for PET services. We're just running a PET service up here at the moment. So we're the only PET scanner in all of the territory. We're in Darwin, and there's the Royal Darwin has about a 370-bed hospital. There's Palmerston, which is sort of on the outskirts of Darwin, which has about another 100 beds or so. And then Alice Springs is about sort of 180 beds. There's no nuclear medicine service in Alice Springs. Catherine, there's a decent hospital with 60 or so beds. Out at Gove, out in the eastern Arnhem, there's also a small hospital as well with about 30 or so beds. So there's not a large amount of hospital patients outside of Darwin. So lots of people come in, but people come in from all around the communities. There are little health services in all these little sort of townships and outstations around. So a fair amount of our population comes into Darwin, and it takes a fair amount of effort to arrange them, obviously. Prior to the PET service, there was obviously no PET up here in the Northern Territory. There was a promise back in 2020. It was actually a Malcolm Turnbull election promise, apparently back in 2010, which was sort of revived over time. And then the 2016 election, they decided to give funds to have a PET service up here because, as you can imagine, patients were here and in need of PET scans or had good referrals for a PET study, but needed to travel to Brisbane or to Adelaide or to Sydney. And there were some 200 patients a year traveling outside of Darwin, so not a large amount for our 250,000 patient population. And as you can imagine, it caused significant delays and distress and strain on the patients and in their cancer journey. Or, I mean, I imagine there were almost no infection imaging or anything apart from oncology going out of the territory. So it really was a matter of lack of equity of access up here, I think. Like, there was some people could have PET service, but it really was a lot of effort, and many people weren't having appropriate PET studies. Part of this 2016 federal and Northern Territory project of expanding cancer services up here was the establishment of a PET CT scanner here, as well as a cyclotron. Although the cyclotron project sort of has been in and out of it as people did various costings in terms of whether to include a cyclotron up here or not. And there were additional chemotherapy chairs. There was an additional CT scanner here for emergency department patients. There was a range of things, but what I came on board and our team came on board was obviously the PET scanner. And the aims were to improve imaging access up here and improve the clinical outcomes as a result. And so a secondary aim was to bring in extra knowledge to the multidisciplinary team meetings, to bring up specialists, to improve the services for people in the territory, to try to bring up the equity of access for people who require these PET studies. And so it's been a while coming from the initial project promise in 2010 up to sort of 2016, when I think funding was arranged. I came on board at the second half of 2018 after the tender had been won for the PET service and building had been commenced for the PET facility. And then we started scanning in December of 2018. This is a picture of, so I just took some photos around the department. As we were, we've got a Siemens biograph up here with an extended field of view. It was, yeah, very happy to have that. It's been a really good scanner for us. This is our control room on the left. I'm not sure if you can see our mouse, but we've got a lovely window. It's the sun come in. This is our staff, or some of our staff down here in the bottom left. So there's myself and Adrienne, the two technologists. In the light blue shirt, the fellow with the beard is Joshua Marigi. He's our physician. So I started at the end of 2018. Adrienne and Joshua started in March or April of 2019. And he's a sort of a full-time physician up here and the director of the service. And then we have Annette, we have admin support, obviously not full-time in doing PET at the moment, but helping us out, obviously. And then we have nurses through the radiology pool. That's Michelle. So I've got a really good team, and we've been stable ever since the start of it, actually. It's been really good, and I think we've been really happy, and it's moving along. Yeah, this is our lab we've got here. So we have a gallium generator and a Eckern-Ziegler generator and Eckern-Ziegler LabEasy synthesis unit as well. So we're getting FDG flown in from interstate, obviously, because there's no cyclotron at the moment. And then we can synthesize gallium PSMA, gallium dotatate as required or as available from that. So just to go through our lab, that's the gallium sits in here. We've got a dose calibrator, of course. We have HPLC and TLC system for our quality assurance back in the corner there, which was helped set up with SAMRI. The SAMRI radiochemist came up to Darwin, and I moved down there, was down there for a bit, to set up acceptance criteria and testing appropriateness for our gallium work. And the gallium has been remarkably stable, actually. Hasn't given us much trouble at all for not having a radiochemist here at the moment. We occasionally do have issues, but the main source of our issues tend to be our reference standards through the HPLC, and sometimes, well, at one time we had a problem with our TLC bath. Like, the product itself through the Eckern-Ziegler system has been really very good and reliable. So yeah, so that's us. We've got 3 uptake rooms that you can sort of see in the back of the camera in the lab, 3 uptake rooms. And Yeah, we're operating. In the beginning, we weren't operating every day of the week, but now we are, and it's keeping us busy and entertained. When I started, I arrived at the end of, oh, sorry, let's go back up this way. I arrived at the end of 2018, and they showed me this as the estimated PET numbers, and I think probably anyone, well, I thought it was low, and I think probably everyone would think it was low. They sort of took these numbers off the number of people they were sending out of the territory, and then I'm not sure how it came up with a 5% growth per annum. And just if I came up here from Hobart and did a sort of back of the envelope calculation of like population differences, and I was like, well, it's going to be at least 3 times that much. But we've actually been more than even this 230 to sort of 280 per annum, that is. So these are monthly scan numbers since commencement in December 2018, which is noisy because we've only got 2 techs and 1 physician. So it's whenever anybody's on leave at the moment, we really reduce the number of studies we can do. So it's noisy mainly for those reasons. You can sort of pick who's on holiday when, as for when we were down, or other things. Obviously, April, May 2020, there was a decrease for other reasons, but we've sort of been steadily increasing, especially when Joshua, our physician, started up here and was able to attend MDTs and able to receive calls and consult with referrers. Really has expanded the use of PET studies here in the territory. We sort of have reached the maximum at we're roughly 100 scans a month at the moment, 30 or so scans a week we're doing, and which is I found the maximum that we can do given our flight time availability of FTG and given our current staffing, and maybe it's to do with the way we do things, but it's a struggle to do more than that. So, but it's certainly keeping us busy. We're scanning every day of the week. We're typically doing about 4 days of FTG scanning with 6 or 7 scans on those days because of the lateness of delivery. And then we're doing another day of gallium work where we typically do 2 gallium runs, depending on how much activity we get out of the generator. But 1 or 2 runs, we do 3 or 4 or 5 patients on a gallium day, for instance. This is a breakdown underneath those numbers in terms of FTG, of course, our most common. We do a fair number of PSMA, which has really been well supported or taken up a lot by the urologists here, including a fair amount of staging PSMA studies, which I didn't do much of when I worked in Tasmania, but it's, so we probably have a slightly higher percentage of PSMA studies as a proportion. That's also, again, I think possibly due to the restrictions of how much FTG we can get up here at the moment, which has always been, or has been, especially recently, a little bit constrained. So all in all, a bit of a general upswing, which hopefully, if demand increases at that rate, hopefully we can fulfill it, but it might require some additional resources for the PET service here. Brief interlude for COVID, because as with everybody, we had quite a lot of disruptions last year. Well, there was a period of 2.5 weeks where there actually were no flights, 0 flights landing into Darwin at times, which we could use FTG. So essentially arrived at a point where we couldn't do anything apart from gallium work. Which was a bit of a shock and a lot of calling around to people to try to see what we can do. After that 2.5 weeks or so, there were flights to Darwin, but the flights were pretty miserable. We had 2 days a week flights from Sydney, which went via Alice Springs and landed at 4:30 in the afternoon here at the airport. Or we had 2 days a week from Brisbane, where they arrived at 6:30 at night. So that was a bit sad. We ended up using that Sydney flight for a few times, and thankfully that flight schedule only lasted a couple of weeks. There were all Virgin flights to Darwin were cancelled. There was no Virgin service to cancel, so we sort of arrived at a point where we were like, oh, we can't really do anything. We reached out through the ANZSNM community. It was actually through the TGA, because one of the struggles we came up against was our usual supplier. Our supplier up until that point had been SAMRI in Adelaide, and there were no flights from Adelaide. There were flights from Brisbane, but we found there was no capacity in Brisbane to supply us. Cyclotech didn't have enough capacity. Brisbane only had capacity on days they weren't supplying rural sites in Queensland, which weren't any of the days there were flights to us. There was Charles Gardner were willing to help us out, but without not TGA license, and they couldn't supply us with very much. Melbourne, there was no extra capacity and no flights anyway. Sydney, we found Liverpool Hospital having capacity but no TGA license. And eventually we worked out with Royal Prince Alfred to supply us, but it took a lot of conversations with our hospital executive, Medicines Management Board, through the various channels of the ANZSNM and RAINS to try to find somebody who could sell us some FDG, because there was a period where we just couldn't have any, and all our referrers were like, well, when is this going to get done? Because patients couldn't travel interstate either to have these studies. So for actually, I think several months, we had to do evening work. We had a few times quite late in the evening where patients were coming as late as like 6 o'clock in the evening, and it required a lot of changes here in terms of not just our staffing, but just in helping patients arrive to the hospital, because lots of patients are reliant on public transport or a hospital bus, and so we had to try to organize taxi vouchers to get them from their accommodation to here, because they couldn't drive. They're leaving here at 8 and 8:30 at night. So it was a big team effort, hospital-wide, our department especially wide, just to continue the service during this period, and keeping everyone informed about the uncertainty, because the flight schedules were constantly changing, flights were on and being cancelled. It was really a very difficult time, but we made it through, even though there's continued to be flight changes, as you, I don't know whether you guys look down there, but half my work seems to be looking at flights and seeing flight changes and wondering when I can get FDG in, because the flight times are changing. But anyway, hopefully that's to change, because the cyclotron project up here is going ahead. At the bottom, I just put one of the good uses of the COVID was they were able to use our PET scanner, because we weren't using it much, as a clean CT scanner to help out with our infection control management. So a small silver lining, but it was a very difficult period. Our normal operations, we get FDG 4 days a week. We do gallium production on another day. Some days that can vary. If we've got a lot of gallium referrals, obviously we can do a second day and drop an FDG day. We normally get, at the moment, we're getting our FDG about midday. During daylight savings hours, the flights are a bit different, and we get it earlier in the morning. So nowadays we're doing sort of typically about 7, 8 patients with that midday start. Whereas at the 10:30 delivery, we can do 8, 9, 10 patients a day with 2 techs and a nurse from radiology. So we're at the moment doing roughly 30 studies a week, 3 days a week getting FDG from SAMRI, 1 day a week getting Liverpool because of supply constraints from SAMRI. And yeah, working really well with, and this is, I suppose, a page just to sort of appreciate the effort of there. And I had never, working in Tasmania, had as good a cancer care coordinator team up here in the Northern Territory. I'm not sure what they've got in Adelaide. There's a team of care coordinators, each dedicated to different cancer streams, and there's actually cardiology coordinators and other coordinators outside of the oncology field as well. But the effort and work and of those coordinators has been really useful, and the Aboriginal liaison officers and the interpreter services. It takes sometimes a fair amount of effort to book and make sure they understand their preparation and make sure they can consent for patients coming in, because if patients live in remote communities, it's hard to, they often won't have a telephone. So we can't just call them, or possibly they do have a telephone, but English is not their first language. So it can be difficult to, so it takes really a whole team and a lot of effort to make sure that patients, when they arrive, are actually prepped and able to have the study, because we're spending a lot of effort to and money to fly this FTG up here. It's like, you know, it's a 4.5 hour flight, 4-ish hour flight. You know, it's like 4 half-lives or whatever in between dispatch and arrival here. Like, it's no small amount of effort to fly the FTG in. It's so frustrating when a patient comes and is not prepped for the study, because, you know, we're not doing FTG every day. It's not so easy just to reschedule. They're in from the community. They might have 3 different studies, 4 different things. They come in for the community. They have a PET scan one day. They're due for a pan endoscopy the second day. Then they're starting their treatment, or I'm not sure how it works, but, you know, they've got a variety of bookings. And if we delay on the PET scan over the weekend or something, it really knocks around all their other schedules. So this is just to appreciate the care coordinator system we've got up here in the territory and how useful it's been. I've put up here as well, just there's a podcast that the Menzies Centre up here in Darwin have done called Ask the Specialist, which I can highly recommend to people interested in especially communicating with Indigenous patients, about getting to know people and just taking the time, making sure you can have consent. It's useful. It's just some specialists in the sense of Aboriginal healthcare workers and people with knowledge of Aboriginal health, just talking. They're just little short, sort of 15-minute podcasts, just saying, here's some ideas about consent, or here's some ideas about, you know, why people might be nervous, or how you can help with language, or how you can help with an interpreter service. I found it really useful, and so highly recommended if you can look that up on podcasts done from the Northern Territory. So that's us and who we do. We're sort of largely got over the COVID situation, and, you know, some flights are variable, but we're pretty much stopped at, as I say, that sort of 30 or so scans per week. But there are some changes coming up here in the territory. The cyclotron project is underway. The building's built largely. The cyclotron is inside the building. We are awaiting the European team of cyclotron engineers to do the actual installation and qualification of the cyclotron itself. And yeah, the installation of the quality control equipment. We've just finished our recruitment of an operations manager, which is going ahead. So we're hopeful to have cyclotron operations in the second half of this year, which will be enormously exciting. And this whole, when the COVID, when I first came up here, I didn't at all think a cyclotron was worthwhile from a budgetary point of view for the Royal Darwin, but having worked here for these couple of years, and I don't know, probably I've become indoctrinated into it. Yeah, over the last year, it would make our lives so much easier, and someone else can judge the cost efficacy, but we're very much looking forward to having it here anyway, and hopefully at the second half of this year. Also this year, the tender for the private single photon nuclear medicine within the public hospital. So at the moment, the public system runs just the PET scanner. So we've got 2 techs and the physician just doing PET service. There's 2 gamma cameras run by IMED at the moment and reported through IMED for a single photon. And it's highly likely that that will be brought into the public system at the end of this year as well. So that will be a big change in terms of our staffing and our operations in bringing on nuclear medicine. And thankfully, I have hopes to sort of improve the integration of nuclear medicine to the rest of medical imaging and improve its use and its images. And then next year, we've been speaking to the people in Adelaide, and I understand, it's at the moment, the radioiodine inpatient therapies are all done in Adelaide because there's never been a inpatient therapy room up here in Darwin. So we have put forward a business case, and we've been scoping out rooms. And so obviously this is not an easy thing to do, but we have ambitions, hopes, plans it will happen, of commencing inpatient therapy up here. Once we've got the cyclotron, we'll have extra staff. So we'll have a engineer operations manager, a radiochemist. Our plan is to employ at least one nuclear medicine technologist at the cyclotron as well. So we'd have 2 techs at the PET scanner, 2 techs at single photon nuclear medicine, and at least 1 tech at the cyclotron, and sort of rotate those staff around if that works, to keep knowledge everywhere and just allow, because we're just allow each of the services to continue when people are on leave and through periods of unexpected leave. So techs, probably an additional physician up here, or a registrar at least, a medical physicist, which we don't have at the moment, will probably become necessary if it's not already. And with that inpatient iodine therapy, we can hopefully, and the cyclotron and less time pressure in terms of the amount of radioactivity we get up here in terms of using it to its fullest, we'll be able to have hopefully more involvement in national PET trials as well, which we'd quite like to, and I think that should be possible. And then with the team, investigate, other radionuclide therapies or anything else that might become possible. So I think it's an exciting time up here in terms of expansion of our staffing, expansion of our scope. I think it'll be a really interesting few years ahead. I think I've got a picture of the cyclotron. This is our cyclotron facility on the campus of the Royal Darwin Hospital, but not actually connected to our building, just off doors. So it's got some lovely windows in the staff area. The cyclotron, this is from last week when they're bringing in the cyclotron it's not actually unpacked. As I say, we're waiting on this European team to come and install it, but it's very, very exciting for us to see that coming. And I guess I just put some random pictures up because I'm like, this is part of I take a little break to advertise Darwin and be like, there will be jobs coming up here. We need new techs and new radiochemists, so keep your eyes out for job applications coming up and down. We've got a really good team up here. It's a really good service, and I think we'd like to welcome other good people to come up here and make it a better service and sort of expand ourselves. I think it'd be really good. That's largely what I've got in terms of what we're doing. I didn't know whether you wanted me to maybe stop and take some questions about who we are and what we are, or whether you prefer me to go on to a case study. Is there any indication from the audience what you'd like me to do?
Does anyone have any questions so far?
It's John Bartholomew here. I can see John Mackay there. And congratulations on the work you all have done establishing the PET service there. No doubt been a lot of work, but it's good to see the numbers. And I think it'll be great when you get your cyclotron in place, because COVID has been a problem.
Mm-hmm.
Will you make enough to export to Adelaide, do you think, or not really?
It's a very powerful cyclotron that they've acquired. It's a matter of flight, like convenience of flights, I think. Like, people have asked me several times whether or not, I mean, I think it'll be capacity. I think we'll have the capacity, but whether there's a flight that leaves and arrives to Adelaide at an appropriate time. I think that's what the limitation is, I think. Yeah, I think the easiest versions will be Cairns. There are direct flights to Adelaide. It's possible, but the flights here, unfortunately, are so infrequent and variable. It's very hard to say. But yes, you're right to point out Dr. John Mackay in the list here, and thank you him very much for his work. He was one of the consultants on the setup of the PET facility up here. He's up here at the moment. When Josh was on leave, he's our visiting medical officer reporting the PET studies at the moment. Thank you, John.
Thank you. I'm sure the numbers will increase looking at that trajectory.
Yes, when we have a cyclotron, we'll, if we have 3 days of 10 a week, and then, I don't know, yes, I'm sure it will increase. Once it's here and the technology's here and people know it's here, there are people who will use it. So,
do you have a waiting list, Jack?
We have a waiting list of sort. At the moment, it's reasonably under control. A bit sort of possibly a bit longer than we'd like it. So very urgent studies can be done typically within a day or two, ideally, including inpatients, but sometimes that stretches out to 3 or 4. And then other study. At the moment we've got appointments next week, so we'll fill up next week with our sort of tier 2 triage system. So since the addition of, we've just recently added a 4th day of FTG scanning, and that's very much helped. When we had only 3 days, we were in a lot of trouble with adding in inpatients at the last minute or urgent studies. So we don't have a lot of a waiting list at the moment, but we are a little bit constrained, and these recent public holidays haven't helped, so not too bad. Any other questions?
Hi, Jack. It's Dom here from Adelaide.
John?
Are you doing much non-cancer imaging, or is it all cancer imaging at the moment?
We are doing a, sorry, I should have, in the beginning, we were pretty much only oncology imaging up until Joshua started in sort of February or March of 2019. And now we do a reasonable amount. Well, I don't have the numbers in front of me, I'm sorry. Yes, we do infection imaging, infection of unknown origin, vasculitis. We've just recently started some dementia imaging, but we've only done sort of 4 or 5 patients, like dementia brain, FTG imaging. And so limited, it would only be 10% possibly of our numbers, maybe slightly under that. So some limited infection imaging, but the infection team for infectious diseases, for especially inpatients up here, have found it extremely useful. So there's been a series of patients we've done baseline and follow-up imaging, because there's some melioidosis, some tropical diseases, and some various infections that have required monitoring, especially with patients with renal impairment who sort of struggle with antibiotic therapies for long term. Yeah.
Thanks, Jack.
Hi, Jack.
Hi, Sarah.
How you going? I was just curious what you do about servicing, like whether it's unplanned, things go wrong, and just your scheduled servicing, where the engineer are coming from.
So at the moment, we're using the Adelaide Siemens engineers. So we did have HIP. So they just get scheduled as normal, the normal preventative maintenance for the camera or for the QC and synthesis equipment. So we thankfully have the ability to, one day every 3 months, or one day how often, just to sort of drop out a day. So just as normal, even though there's no patient scan on that day, we're not that busy that the loss of one day will bother us. And actually, even we still have the ability to drop out a day when, for instance, the emergency department CT scanner has a service, and we'll give up a day of PET scanning for the ED-CT to come around here and do scanning on those days when they're having a service. So at the moment, we still have scope to help out other people as well. So we're thankfully not that busy at this point.
Sorry, just one more question too. I might have missed it before, but do you have your own receptionist who does the bookings, or are you guys doing the bookings yourself?
We thankfully have our own receptionist. There was a period in the start where I was largely doing the bookings myself, and I hated it. Yes, we do. We have she's theoretically a 0.5 at the moment. We have our own dedicated receptionist just for PET only. She does do other work for admin here, but the PET actually is taking up a large amount of her time. So we have our own PET receptionist, and probably even when we take over nuclear medicine, that'll sort of expand into at least a full-time position for PET and nuclear medicine together, I suppose. Yeah. It's too much for the techs to do the bookings.
Jack, when you take over nuclear medicine, is that radiology as well? Is that the plan? Is that IMED is giving up the site?
My understanding is that the tender will be ending for actually radiographers and physical operations of the cameras, but that the reporting and interventional radiology will be put back out to tender, and that IMED will probably bid on it. I think, or it's still, it's going to be re-tendered as a reporting only and interventional radiology service. But the nuclear medicine, because we've already got a nuclear med physician up here, he's the only doctor employed by the public service within medical imaging, Joshua. So I think nuclear medicine reporting will be taken in-house, but the radiology, I'm not involved with the detailed discussions of it, but my understanding that radiology reporting will still be tendered out to a private company.
So nuclear medicine is going to be run by you guys, by the public service, and everything else by whoever wins the tender.
So when you say run by, so all the radiographers will be public radiographers, top-end health service, the nuclear medicine technologists, but the reporting for the MRs and CT scans, my understanding will be they'll still be going to private radiologists. You have to excuse me, I'm not entirely involved in the details of it. There's negotiations about the tender ongoing, so. But my understanding is that, that the radiology reporting will still be outsourced, because it's a lot of effort, as you imagine, to employ the number of public radiologists required to take on that responsibility in short notice.
Hi, Jack. Dean Topham here. Can I ask you, with your blood sugars and the diabetic patients up there, how have you been finding that?
Today was an interesting day. We had a ward who decided to the BGL was like 17, and they decided to give like 3 little titrations of Nova Rapid until came down here, and the BGL came down and down and down and down and down until it was like 3.8 or something like this. In general, okay, really. We have, most patients when they arrive have a reasonable EGL. We haven't been giving insulin here as directed by our nuclear medicine physician on site. He's not willing to do that, so he'd be the person to speak to about it. But occasionally he will do images when it's slightly higher than 11 millimoles, or wait some time and sort of, delay until later in the day to do the scanning. But most of the time we do, during bookings, we find out if the patient's diabetic, obviously, and then prior to the appointment, I didn't mention in terms of the scheduling. So the admin makes the booking initially, and then the day prior to the actual PET study, Adrian or myself, one of the technologists, calls the patient and just sort of has a chat about their diabetes, if they're diabetic, and just whether it's well controlled, whether they, finding out, if it's not well controlled, sort of referring it on to endocrinology or something. But most of the time, we've been pretty fine. Yeah. Today we just had an issue with somebody just giving a bit too much insulin in the ward and then sending them down to us. I'm not sure if that answered the question. Sorry, Dean.
Sorry, Jack, it's just Sarah again. Do you get many no-shows for patients, or once they've been booked in, they're pretty compliant at turning up?
We sometimes, but actually not very many, because we spend a lot of effort in making sure a patient comes. Like, we don't schedule patients in without having spoken to the patient or spoken to a cancer care coordinator or one of the community health workers in the remote communities, who will say, this patient, we've booked the travel, this patient's coming in. And then we'll check in the days leading up to it to see whether the patient has attended the travel, for instance, the day prior to the study. So, and then obviously there are occasions, somebody wakes up in the morning and they don't feel well, or somebody, there's weather, like in the wet season, some roads are blocked up here and patients can't come into town. But hopefully most of the time we catch this the day before when we give them a call and confirm the study. So we have been doing that actually over the phone in person to date, which is a fair amount of effort. But just because it's so frustrating to, we've got occasionally have a wait list, and if patients don't attend, we don't have a lot of flexibility with the amount of activity we get of saying, oh yeah, we'll just wait in the afternoon, we'll get someone to fast from now and we can do it in 4 hours time or whatever. It's just not possible because we're not getting our activity till the afternoon. So that's to say, Sarah, we get actually quite few non-attendances, like comparable to what I would have got at the Royal Hobart, really, but it takes a lot more effort with each patient and each scheduling to make sure that happens. Our most common issue regarding an appointment is still patients coming in from remote communities who don't understand the fasting and the necessity of the fasting, and that's even though it gets sort of explained on multiple occasions, that sometimes that not uncommon for someone to come in and be like, I just had something to eat, you know, an hour ago or half an hour ago, and typically we just have to wait on those patients, have them sit and scrounge out the last bit of activity, and sometimes work a little bit later into the afternoon to complete it, because, you know, otherwise what do you do? Send them back home and reschedule it. It's not really doable. So not many no-shows, but some lack of proper preparations, mainly due to misunderstandings, I think.
I've just got one last question, I promise. Can you ever see down the track a point where they might need a second PET scanner? Do you think that there'll come a point that that's a possibility? And is that an option as well?
A possibility, certainly. I mean, our PET scanner here is underutilized, like the actual physical existence of the PET scanner, because as I said, at the moment we're not getting our any FDG until 12:30 in the day, so we're not 12 o'clock in the day, so we're not doing scans until after 1. So once a cyclotron's here, we'll have more opportunity to utilize this particular piece of machinery to a fuller extent. I suppose the second thing against that is that once the cyclotron is up here, the actual marginal cost of somebody else putting in a PET scanner, a private PET scanner, and having easy access to radiation, because there'll be surplus produced, one imagines. So it wouldn't surprise me if one goes in, but in terms of the actual demand on it, once we have a easier flow of radiation, of radiopharmaceuticals here, the actual, you know, it's just a matter of staffing this camera differently, like having a morning shift and an afternoon shift or something, I imagine. Yeah, so possible, but more, I suppose, to do with a private company coming in, possibly, rather than actual demand for our service, because I think it'd be easier to just staff this one more rather than buy a whole second camera.
So you have capacity to scan more if you wanted to. So the limiting
If we had with more staff, I think is the issue at the moment, in that with only 2 techs, we would need sort of longer days to cope. Like the patients are a little bit more intensely sort of requiring of attention than possibly the patients I'd previously regularly encountered in Tasmania. So it's a bit more involved from a tech point of view. So I think for longer days and more scannings on this particular camera, we need more staff. But then it's once we get more staff normal nuclear medicine, we have 2 techs in nuclear medicine and 2 techs here, and, you know, potentially a tech in the cyclotron as well, that maybe there's a way of, you know, rotating the shifts around to have more staff on here, well, for a longer period of the day. So yeah, there's capacity on this machine, but it just requires the staffing to be sort of arranged slightly differently.
Are there any other questions? Jack, did you want to do your case study presentation as well?
Would you like me to? It's quite brief, I think. I'm not sure, I've never done it before. What time? Yeah. All right. I'll go quickly, and if I don't know what time you normally leave, but it's not.
There's another presentation here afterwards that's not on the agenda, but we've got some students presenting as well.
And do you normally finish at 7:30, or when do you normally finish?
It doesn't matter. There's no fixed time.
All right. I'll quickly do this. We have a lady that we've done some sequential images with malakoplakia, which is a inflammatory condition, can affect different organ systems, commonly the urinary and GI tracts, of unknown pathogenesis, but frequently associated with immunosuppression. Commonly with this bacteria as well. And risk factors are as listed there. There happens to have been, back in January, like document number 2 here, something in clinical nuclear medicine, a interesting image of malakoplakia. And it was, we had done this lady 3 times last year and back in January today. And so that's, and I don't think I had seen this disease presentation in FTG before, but not that I've worked here as long as others have. Risk factors include organ transplantations, tissue disorders, neoplasms, diabetes, and other sort of immunodeficiency disorders. Can have variable clinical manifestations, and its appearance makes it a bit difficult to diagnose. It's usually diagnosed under biopsy and culture. But FTG PET can be used to determine disease extent and also, I suppose, response to therapy, as in this case. This is MIP, and it's this highly FTG avid sort of area in the pelvis and throughout the lymph node chain. So, obviously for FTG PET, the differential diagnosis includes infection, other infective etiologies, and malignancy as well. But in this particular case, we had a lady who presented to the hospital with bleeding and pelvic discomfort. She was an end-stage renal failure patient who had a renal transplant 8 years prior. They did a biopsy of this mass that they found and found this E. coli positive pelvic malakoplakia, which is a pseudotumor in the setting of immunosuppression following her renal transplant. They put her on antibiotic therapy at a renally adjusted dose, and she had some symptomatic improvement, but then they referred her across to us just to sort of assess the extent of disease, I suppose, or to see, they were reluctant to have her on prolonged antibiotic therapy. So we did a series of PET scans on her, dating from, on the left, July of 2020. We imaged her sort of 7 or 8 weeks later in August, and then a couple of months later again, and then a few months later again. And you can see from these images that sort of the initial sort of dual foci, these sort of intense two areas of uptake within her pelvic fossa sort of were highly intensely FTG avid, and that she had sort of intensely avid lesions in the left common iliac station as well, and left para-aortic stations. With similar etiology as reported on the FTG study, suspicious for this known malakoplakia, unless they suspected, the clinical team suspected any other malignancy, which they didn't at the time. So it was reported as, suspicious for the known malakoplakia. She was on this antibiotic therapy, and then following the initial FTG PET study, because according to that, disease burden was bigger than they had known at diagnosis, they added ciprofloxacin added to her antibiotic therapy. And then we did another PET study, this second one, which was largely the same. It was a stable burden of disease following the continued antibiotic therapy. Ongoing intense FTG activity within the lesions and in the iliac and the lymph node stations as well. She did, you can sort of see it on this image, also have sort of a rib trauma as well on the right side, but stable burden of disease. And then they did a surgical debulking in September, which they reported as difficult due to the anatomy, with some residuals due to tumor left behind. They cultured those and they were positive for ESBL or E. coli. So after their surgical debulking in September, they sent her back to us again in November for another FTG study, and there was an almost complete metabolic response. There's a sort of, it was reported as only having minimal residual area along the pelvic side wall in the November imaging. And so then shortly after that, she completed her antibiotic therapy and then sent back to us again in February. And we have this lovely sort of no residual, sorry, I'm spinning wildly images. These are the initial, on the left, transaxial images of the hypermetabolic areas and lymph nodes, and then equivalent areas, the February after the completion of the antibiotic therapy. where there was no residual hypermetabolic activity. And to date, she's had a complete recovery. There's no sort of relapse of her symptoms or no evidence of any residual disease. She has had a rise in her creatinine levels, but unrelated, one expects, to this disease burden, which seems to have been both surgically and antibiotic therapy sort of cured, one hopes. I'd never seen one of these cases before. I thought it was interesting. It certainly is, it's very, as you know, FGG is not very specific, so it's highly mimicking of other disease processes. But in this case, obviously, she had been diagnosed by histology prior to attending us on the first occasion. But I just thought that was an interesting series of imaging that we've done up here. So certainly we do infection and other sort of non-oncology imaging. I think that's it. That's as short as it gets. Thank you to Adrienne, the other tech who I know is on the stream, and John Mackay, our physician who's on the stream, and the entire team up here, actually. Joshua, who left me with no effort of his own on this presentation. But many thanks to him and the entire team up here.
Well done, Jack.
Thanks.